Small B-cell lymphomas are part of our daily landscape as pathologists, but their workup can feel overwhelming and the differential diagnosis can have overlapping features. One of my friends is convinced that the workup of lymphoma cases clogs up our immunomachines. In this series, you will get a clear roadmap on how to approach these entities with confidence. And we start with the most common one of them all, follicular lymphomas. So hang on tight, grab the beverage of your choice. I've got chai, and I'll meet you at the scope. Okay, friends, let's start with our case. And right from the get-go, there is something that I would like to point out to our trainees. See, this is a very nice open biopsy with a massive lymph node of a middle-aged male with generalized lymphadenopathy. But a very important thing that I would like to bring your attention to is the crossing of the lymph node and any other specimen. You see, when we put a very large fragment of tissue in the cassettes, it leads to a suboptimal fixation and it compromises the morphology, especially of delicate matters like the nuclear details of lymphoid tissue. So here you can see how because the tissue is big, it is touching the borders of the cassette. Probably it was too thick, so it leads to underfixation of the lymph nodes at the periphery. For example, here, so we can tell that it's underfixed when it has these artifacts, when it has this breaking down of the tissue, and then when there is clearing around the cells, you can tell that it's probably suboptimally fixed. Now, nevertheless, we need to make do with what we have. And let's look at this lymph node. So this is a cervical neck node of a middle-aged male patient who presented with generalized lymphadenopathy. As you can see here, the architecture of the lymph node appears to be effaced with what appears to be a nodular or a follicular pattern of infiltrate. The subcapsular sinuses are effaced. They are not patent, and there is some kind of infiltrate within them. And then let's go high power and see. So it has this round follicular or nodular pattern. The infiltrate mostly consists of small to medium-sized lymphoid cells. They have this irregular nuclear membrane or contours. They seem to have a mature clumped chromatin and not a lot of large cells within the infiltrate. Let's go around and see if we can see other features. So again, here you have in this nodular area, small to medium-sized lymphoid cells with not clumped chromatin. You don't see large cells, so really you don't see a lot of large cells at all, at least by going around in this area. One of the issues that we need to consider here is whether these nodular or round structures or follicular structures that we see, are they normal germinal centers or are they atypical proliferation or atypical follicles or neoplastic follicles? So if we compare it to the germinal centers that I showed you in our lymph node histology episode, they certainly don't have a reactive germinal center in the middle. They don't have a mantle. There's no polarization. And all you can see is this nodularity or a proliferation of a follicular pattern. Differential diagnosis of this pattern is we are thinking of a lymphoid infiltrate. It appears to be neoplastic because it is monotonous. There's no mixture of lymphoid cells. There's no polymorphism. All you can see is monotonous sheets of these small to medium-sized lymphoid cells. Over here, you can see maybe one larger lymphoid cell, and it is growing in a follicular/nodular pattern. So in this group, when you see this kind of morphology, we think of an umbrella of differential diagnoses, which are under the category of small B-cell lymphoma proliferation. Now, this is given that these are B cells. So let's head to the still images and show you some immunohistochemical stains. So these are the still images from the similar case, and you can see here that you see this nodular/follicular pattern, which is more prominent over here. But by low power, you can see that you don't see the reactive germinal centers that I showed you in the lymph node histology episode. And there's no polarization, there's no changeable body macrophages, there's no cortex or medulla. Everything is the lymph node architecture is totally effaced by this follicular pattern of proliferation. Closer view, and again, this is due to the suboptimal fixation where you see this cohesiveness and breaking down of the lymph node architecture. However, you see that those follicular areas are effaced by a monotonous proliferation of small to medium-sized lymphoid cells. These lymphoid cells have this irregular nuclear membrane, so almost like cleaved nuclear membrane or centrocyte-like morphology. For example, here, look at these, the centrocyte-like morphology, and then you see the occasional, very rare, large lymphoid cells with the vesicular chromatin and very small prominent nucleoli, which might be a centroblast. Over here, high power view that can show you the centrocytes, or what we are assuming to be centrocytes. Look at these nuclei with the irregular nuclear chromatin and the cleaved nuclear membrane. So we started with a general panel. You will start with a CD3 and a CD20 and see where it leads you. And this is the CD20, and you can see the CD20 is diffusely positive in the whole lymph node, which gives you the clue that you are probably dealing with a B-cell lymphoma. Now, we have decided that you have a lymphoid proliferation that is small to medium in size, that is B-cell, and it's growing in a follicular/nodular pattern. And again, as I mentioned, so this will be under the umbrella of small B-cell lymphomas. As we go through the series, we will discuss all the different differential diagnoses, and then we'll lump all of them together and we'll consider all the differential diagnoses in one last episode and compare all the immunohistochemical stains. But for today, we will concentrate on one differential diagnosis, so it hones in and you can diagnose this entity with confidence next time you face it. So as we were saying, CD20 is strongly positive, BCL2 is positive in those nodular/follicular areas, and as I showed you in the lymph node histology, BCL2 is negative in a reactive germinal center. However, here it's nicely positive. CD10 is positive in those areas. BCL6 is positive, and CD21 highlights this follicular/dendritic meshwork. So with this morphology and immunohistochemical stains, this is characteristic of follicular lymphomas. And then after follicular lymphomas, what you want to tell the clinician is how to treat it, and this will depend on the grading. So whether it is you follow the ICC or the WHO 5th edition, so either you can tell them this is follicular lymphoma grade 1, 2, 3A, 3B, or this is a classical follicular lymphoma, which encompasses all the low-grade lymphomas. So with the morphology that we saw and no increase in number of the centroblasts, this will probably be a follicular lymphoma grade 1 to 2 or a classic follicular lymphoma. Ki-67 is also helpful as it will not show polarization as in a reactive germinal center, but it's usually lower than a reactive germinal center in follicular lymphomas. However, any Ki-67 above 30% might indicate a worse prognosis. So a couple of words of follicular lymphoma, and then I'll show you some real cases from different subtypes so you can have a general or broad idea of all the spectrum of follicular lymphomas. Follicular lymphomas, as we said, is one of the most common lymphomas in the Western world, and they arise from the germinal center. So you would expect them to arise from this zone of the lymphoid follicle, and they consist of centrocytes and centroblasts. It can have a follicular or diffuse growth pattern or a mix of follicular and diffuse. Now, Now here, let's compare a reactive germinal center over here. So you can see here all the polymorphous lymphoid infiltrate. You have in a reactive germinal center, you have centrocytes, centroblasts, immunoblasts, follicular dendritic cells, tangible body macrophages, and then it is surrounded by a mantle zone. However, in a follicular lymphoma, we call this pattern naked follicles. So you don't have the mantle zone around them, and then it is just a monotonous proliferation of small to medium-sized lymphoid cells. And now there has been some changes in the WHO 5th edition for the follicular lymphomas. So the main entity is follicular lymphoma, and it is divided into some morphological variants, and then you have subtypes of follicular lymphomas. So the subtypes, let's look at it here. The subtypes of follicular lymphoma is the main follicular lymphoma, then in situ or pediatric, duodenal type, and primary cutaneous. As I told you, the main follicular lymphoma is further divided into classical follicular lymphoma, or in the old classification or ICC, which used to be divided into categories, which is grade 1, 2, and 3A. And then you have another subtype, which is called predominantly diffuse pattern. This is just a morphological variant and not a specific subtype. After that, so you have the classical, the predominantly diffuse, you have the follicular large B-cell lymphomas, or what used to be called 3B. The last morphological variant is the follicular lymphoma with uncommon features, and these consist of the blastoid and the large centrocyte variant. So more and more studies are emerging and description of follicular lymphomas with these atypical features, but you still can't push them into the category of transformed follicular lymphomas. The classic follicular lymphoma will have partial follicular growth pattern, and as we said, they will have a mixture of centrocyte and centroblast. They encompass grade 1, 2, and 3A, and they have the classical translocation 1418, which involve the IgH and BCL2 genes. The immunophenotype that is characteristic of follicular lymphoma is of a germinal center cell origin, because they arise from the germinal centers. So you expect them to have CD10, BCL6, LMO2, HGAL, or MEF2B. We don't have all of these immunos in our lab, so we depend on CD10, BCL6, LMO2, and then some of the follicular lymphomas, you must keep in mind that they might lose the CD10, especially the diffuse areas, or the higher grade follicular lymphomas can lose CD10. Then the other characteristic finding is BCL2 positivity. You should know that all of the small B-cell lymphomas will be BCL2 positive. So you cannot use BCL2 alone to differentiate the different small B-cell lymphomas. However, it is very helpful in differentiating it from a reactive germinal center. So a follicular lymphoma will be BCL2 positive, just like the case that we saw today. And the lack of BCL2 expression is seen in follicular lymphomas, and this you should keep in mind that it might be due to a mutation in BCL2 gene that affects the epitope recognized by the antibody that you're using in your lab. And BCL2 is also can be lost in higher grade follicular lymphomas. So the pitfall here is a reactive primary follicle which has not undergone a mutation, and it is not a secondary reactive follicle. The primary lymphoid follicles, which is all IgD positive, can be BCL2 positive. The next immunophenotypic finding is the presence of follicular dendritic meshwork that can be seen by CD21, 23, and CD35. So use any or use in combination to express the follicular pattern. You can use Ki67. As we said, the Ki67 in a reactive germinal center shows you this nice polarized pattern, and you expect them to be very high, whereas in the classic follicular lymphoma, which is grade 1, 2, and perhaps 3A, you have a lower Ki67. Of course, high Ki67 might be seen in a low-grade follicular lymphoma, but anything more than 30 would indicate a worse prognosis. The difference between the old WHO classification and the updated 5th edition is the grading of follicular lymphoma is considered optional, as it was found that grade 1, grade 2, grade 3A all have good prognosis, and it doesn't really matter if you grade them or not, so you can lump them all together under classical follicular lymphoma. However, speak to your oncologist, see what they would rather have in the report, and you give them that information. Personally, I give them both classifications, the ICC or the old WHO classification and the updated 5th edition. So let's look at some examples and see how you would approach it in your daily life. So this is a needle core biopsy here, and this is an example where I want to show you that even if you get a needle core biopsy and it is a first-time diagnosis, if it is a good needle core, you will still be able to see good architecture and you will be able to reach a good final diagnosis. So this is a needle core biopsy. As you can see here by low power, there is this nodularity, and it seems to be effaced with this monotonous lymphoid proliferation. The high power view shows you sheets of these small to medium-sized lymphoid cells. Again, they have this irregular, notched or cleaved nuclear membrane. They have a clumped chromatin, and then you have the occasional centroblast. For example, this is one centroblast with the vesicular chromatin and two prominent nucleoli at the periphery. You have the FDC. So this is a good point here also, that often FDCs can be mistaken for centroblasts during grading of follicular lymphomas. So pay attention and do not overcall these as centroblasts. So CD20, as you can see, was nicely positive, and it brings out the follicular pattern. CD10 was positive. CD21 gives you follicular dendritic meshwork. BCL2 was strongly positive, and Ki67 low. So this, if you are ICC, pro-ICC, you will call it follicular lymphoma, grade 1 to 2 out of 3. Or if you want to give them the updated 5th edition classification, you would call it classical follicular lymphoma. Now, another way to approach it is, if your oncologist prefer the 5th edition classification, you would say classical follicular lymphoma, but it's always advised, and I heard it from many experts, that give them both classifications so the oncologist can decide what to do if it really matters to them. For example, if it is a 3A, for example. So for this case, I would say classical follicular lymphoma, ICC equivalent to follicular lymphoma grade 1 to 2 follicular pattern. Now, let's see this next case. Again, you have this follicular pattern, but now it is lighter. So once it is lighter or more pink, that means you have more cytoplasm in the cells. So let's see what kind of cells they are. Now, if you compare this morphology to the one I just showed you now, these are larger cells. They have vesicular chromatin. They have prominent nucleoli for sure, and they have moderate amount of cytoplasm. So this morphology, in the background, you have scattered rare centrocytes. So this is again a follicular lymphoma, but here the centroblasts, if you count them, there are more than 15. So this will be ICC follicular lymphoma grade 3A because you still have the centrocytes. So this will be a classical follicular lymphoma in the 5th edition. However, ICC equivalent to follicular lymphoma 3A follicular pattern. Now, let's look at more morphological variants. The next is follicular lymphoma predominantly diffuse pattern. This is considered as a subtype of the classical follicular lymphoma. It corresponds to, in the ICC, to BCL2 negative, CD23 positive follicular center cell lymphoma. Often presents in women in the inguinal area. You might see it in the axilla or cervical region, but they are usually localized with stage 1 to 2, and they might present with a microfollicular pattern, even though they are commonly diffuse, or predominantly, let's say, diffuse. So immunohistochemical stains, they're characteristically CD23 and BCL2 positive. CD10 and BCL6 can be variably expressed and might be lost. So this is one of the follicular lymphoma subtypes that you might lose the germinal center markers such as CD10 or BCL6. They often harbor STAT6 and TNF RSF14 mutations, and they lack the 1418 translocation. So let's look at an example. This was a middle-aged lady who presented with an inguinal mass, and you can see here the PET scan showed you only this localized um, uh, positivity or uptake here, and we were very lucky to get a resection of the lymph node. You can see here diffuse sheets of what seem to be lymphoid cells, and by this power they seem to be small in size, but let's make sure. So yes, indeed, they show the proliferation is monotonous. It consists of lymphoid cells, and it is small to medium in size. If you compare it, for example, to the epithelioid histiocytes or endothelial cells, they are small in size. The chromatin is clumped, and you have some irregular nuclear membrane over here. So CD10 was positive, CD23 positive, obviously CD20 was also positive, and so this was a very elegant case of follicular lymphoma with predominantly diffuse growth pattern, and the patient only had this localized lymph node in the inguinal region. Okay, so let's look at the next subtype, which is follicular large B-cell lymphomas, or which would be equivalent to grade 3B in the ICC or the old classification. It consists of germinal centers that exclusively harbor centroblasts. Typically, centrocytes are absent here, but you still want to see the follicular pattern. So there is no such thing as diffuse follicular lymphoma grade 3B. If you have a diffuse 3B, then this is a full-blown diffuse large B-cell lymphomas. Now, the whole idea for renaming it follicular large B-cell lymphoma is that they are closely associated with diffuse large B-cell lymphomas, and the gene expression profiling of follicular large B-cell lymphomas is very close to diffuse large B-cell lymphomas. So let's look at this example here. Now, can you have this lymph node with a vague follicular pattern? High power view shows you sheets of large lymphoid cells with vesicular chromatin and promonucleoli. So if we didn't have the architecture, I would even think that this is a diffuse large B-cell lymphoma. But once you document that this has a follicular pattern, you have a germinal center cell marker positivity, CD21 is positive, then you can go ahead, call it follicular large B-cell lymphoma by WHO 5th edition, or follicular lymphoma 3B out of 3. So next entity that I would like to shed light upon is pediatric-type follicular lymphomas. These are very interesting types of follicular lymphomas that are localized nodal B-cell lymphomas occurring primarily in the pediatric or adolescent patients. Most cases have been diagnosed in the head and neck region, and they present with painless lymph node enlargement without B symptoms. So they are purely present with purely follicular growth pattern, elevated proliferation index, so they might mimic a reactive germinal center. They are positive for CD10 and BCL6 and negative for BCL2. They are characterized by absence of BCL2, BCL6, and IRF translocation. So as you can see here, this is where the problem arises. They have a follicular growth pattern, they have a high Ki67, and they are BCL2 negative. So all these can easily mimic a reactive germinal center, especially in a young child. So let's look at an example of a patient. So this is a 4-year-old child who presented with a neck or lymph node enlargement in the head and neck area. A whole PET CT showed only this localized enlargement in the nasopharyngeal area, and the biopsy showed expansile follicular pattern proliferation. As you can see here, they are very large follicles, and the follicles consisted of this almost blasty-like or large for sure lymphoid cells with vesicular chromatin and promonucleoli. They didn't look like centrocyte, but they are in midway between centroblasts or centrocytes. Though the Ki-67 was high, but is not high as a reactive germinal center, and it lost the polarization. CD10 was strongly positive, and BCL2 was negative. MUM1 was negative, and we sent it for immunoglobulin gene rearrangement, which was also positive. So without the IGH gene rearrangement, this might be a difficult call. But once you have it positive and you have the correct background of a young child with a localized head and neck region, you can call it a pediatric type follicular lymphoma. This is another example of a patient who was 30-year-old with a localized mass in the neck area. And this mass was excised, and you can see here by low power, it has this vague nodularity. Definitely the lymph node architecture is effaced. Some of the infiltrate is spilling outside in the perinodal fat. And again, it consists of sheets of large lymphoid cells, vesicular chromatin, promonucleoli, abundant mitoses over here. So you might think that this might be a diffuse large B-cell lymphoma even. CD20 is positive, but as you can see, it shows you this vague nodularity. BCL6 is strongly positive, but BCL2 highlights this very nice negativity like a serpentinous follicular pattern. CD10 positive, Ki-67 was extremely high. So at the beginning, we thought or entertained the differential of diffuse large B-cell lymphoma. However, the patient was a young male, localized mass to the head and neck region, no B symptoms, and you can have the morphology of a large cell morphology or a high-grade morphology with a germinal center cell marker CD10 BCL6, BCL2 negative, and CD21 positive. So all this, putting them together, you propose the differential diagnosis of pediatric type follicular lymphoma. So when you are faced with this kind of morphology in a young patient, you think of pediatric type follicular lymphoma, you think of IRF4 large B-cell lymphoma. This is why we do MUM1. And if you have a similar case with MUM1 and CD10 positivity, always think about IRF4 large B-cell lymphoma. And if you have access to FISH or studies for IRF4 translocation, send it for IRF4 translocation. The other differential, if in the testicular area, there's also a subtype that is testicular type follicular lymphoma. Okay, another subtype is the duodenal-type follicular lymphoma. It mainly involves the second part of the duodenum, incidental and very indolent lymphomas, which will be picked up during a routine endoscopy. And this is a very elegant case of a prominence in the duodenal mucosa during endoscopy, and you can see here the lamina propria is studied by these round follicular structures. Over here by low power, you can see they are very, or reminiscent of germinal centers. We call them like a balloon glove appearance, so as if you have blown through a glove and you have the villi swollen by the lymphoid follicles. The high power view shows you the lymphoid follicles here. They are not polymorphic. They don't look like reactive with the centrocytes, centroblasts, immunoblasts, FDCs, etc., but they have a monotonous proliferation of a very nice central size with a small to medium-sized lymphoid cells, clumped chromatin, irregular nuclear membrane, cleaved or notched nuclear membrane. So CD20 strongly positive, and BCL2 is very nicely positive in the germinal centers, CD10 positive. So these are very typical case of an indolent duodenal-type follicular lymphomas. Now, the last thing that I would like to bring your attention to is most small B-cell lymphomas can undergo transformation. So the follicular lymphoma is known to undergo transformation, and the various types of transformation that it can present with is diffuse large B-cell lymphoma, or a high-grade B-cell lymphoma, or what used to be called double-hit lymphoma. It could have a high-grade B-cell lymphoma with TDT positivity, rare cases of transformation to classical Hodgkin lymphoma or histiocytic dendritic cell sarcomas have also been reported. Let's look at one example and we'll wrap it up for today. So this is a patient who is known to have follicular lymphoma and has been treated, now presents with generalized lymphadenopathy and aggressive course with B symptoms. Lymph node biopsy, as you can see, this is the needle core biopsy. Even though they are small cores, you have here some extensive necrosis, and high power view here shows you sheets of lymphoid cells with high NC ratio and almost blasty chromatin, fine chromatin, and crushing artifact. So if I look at it without the context, I would think of perhaps lymphoblastic lymphoma, Burkitt lymphoma, high-grade B-cell lymphoma, and this is CD20, which was positive. Ki-67 was wall-to-wall, almost 100%. TDT was negative, and MYC was strongly positive. BCL2 was positive by immunohistochemical stain. We sent it for FISH, and indeed MYC and BCL2 was positive. So this is an example of high-grade B-cell lymphoma with BCL2 and MYC translocation in a background of follicular lymphoma. So that was it for follicular lymphomas. Obviously, this is not a comprehensive lecture dealing with all the pathogenesis of follicular lymphoma, but concentrating on the morphological findings and the approach to small B-cell lymphomas. In preparation of the next episode in this series, I invite you to review the lymph node histology, which will be linked in a card above. And as always, stay curious, keep learning, and enjoy your Shai. Until next time.